Well, this gets set up. That's a great setup for what I'm going to talk about also. I'm Josh Bamberger. I'm a family doc from San Francisco. And I used to work with Jennifer at the United States Interagency Council on Homelessness. And one of the greatest days in my professional life was when she took me for a walk around Grant Park, where our president gave his inaugural, or not his inaugural, but his speech upon winning the election. And she, sort of talked to me about what I might be doing for the next few months, and then I was able to be detailed to USICH for 6 months working with Jennifer, and it was such a great joy. And one of the last days that I was there was we had a meeting with Grant Colfax, who was at that point the head of the Office of National AIDS Policy. And it was a kind of nice day in Washington, and I drove one of those red share bikes down to the White House, my only time that I actually got in the White House. And when I got there with plenty of time, before it started, there were no places to return the bike. I don't know if you've had that experience where you're working on a good time, you're at 45 minutes ahead of time, but there was no place to turn the bike in. So then I looked on the little app and it said, there's another bike rack a block away. So I biked there, and that one was full too. And then I went to the third one, and there was one spot left, but it was across 8 lanes of traffic, and there was another bike. There was another bike that was coming the other direction, and I had to decide, do I risk my life to get across 8 lanes of traffic to put this bike away so that I can be on time to meet with Grant Colfax? And I was like, I don't know what to do. I don't know what to do. Should I go across the lanes? And then I didn't, and then the guy who was on the bike drove past, and I was able to get the light, and I got the bike in. So hopefully that will be a metaphor for the kind of work. Yeah, it was a heartwarming story. And speaking of heartwarming, so when I started working in San Francisco, this isn't so heartwarming actually, there was no treatment for HIV in terms of medication. And I started working at San Francisco General in 1989, and one of my closest friends was running the large AIDS ward at our skilled nursing facility in San Francisco called Laguna Honda. And believe it or not, he pronounced 900 people between 1992 and 1998. And the life expectancy of people who came into his ward was 28 days. So when you think about that, an era that is thankfully in our rearview mirror. But for me, as a doctor who's spent my whole life working with homeless people, we're sort of in that era now for people with homelessness, mental illness, and substance abuse. The likelihood of living to your full life expectancy is very low for people who are living with these other things. And yet we have what we know is a similar treatment. While we finally developed antiretroviral treatment in the mid-90s and had no ambivalence about prescribing them, we now have a treatment called housing that we are not figuring out how to implement as a healthcare treatment. And Jennifer works very hard to make that work, but we still haven't found the secret sauce. And I'm going to talk to you about why that's so critical if we're going to make any headway on the people who we need to serve today, to be able to look back in our rearview mirror and see that we have been able to treat the people who we care and love in a way that they won't die prematurely. Okay. All the ones are fine. So in San Francisco, we've thankfully had Mitch Katz and Mark Trotz for many years, who now have moved down here to Los Angeles, and we have developed a lot of permanent supportive housing for people living with substance abuse, mental illness, and chronic medical problems. Here is a graph that depicts how we have increased the portfolio of housing for people in this category. And you can see that in 1999, when I started working with Mark, we had 1 building, and by the end of that year, we had 253 renovated SROs in a master lease setting. And then by the time we got to 2015, we now have 1,700 units of permanent supportive housing, half of which are new buildings designed specifically to serve chronically homeless single adults. These are some of the pictures of these buildings, which you'll be seeing similar buildings here in Los Angeles, and Mark will talk more about this afternoon. It's such an exciting time to be here in this city, where there are at one point 86,000 people who've been counted as homeless. We have such a great opportunity and such a great investment in leadership here. So this is the Windsor Hotel, our first renovated single-room occupancy hotel. Then we had our new building called the Plaza. And they all have names like this, Windsor, Plaza, I don't know. And this was like a LEED certified, platinum LEED certified building with serving 106 chronically homeless adults. Mission Creek, just down the street from the hopefully soon-to-be world champion San Francisco Giants. I'm sorry, Dodger fans. But it is right next door. Right now. And then Richardson Apartment, Kelly Cullen Community, which is our largest building, 174 units, took $90 million of ERA funds to renovate this building built in 1909 to house 468 people who lost their housing because of the 1906 earthquake, and now we're going to turn it around to, filled it with 172 homeless adults. And then Renee Kazanov Apartments. So that's just sort of the introduction before I get into the data. I wanted to focus predominantly on data today, and I think this is really critical, important data that hopefully can move the conversation forward about why housing is a necessary treatment to serve people who are living with homelessness and HIV. This is an old slide, and this slide shows, if you look at the bottom lines, Kaplan-Meier curve, the bottom line shows that over a 5-year period, there were about 700 people in San Francisco who had AIDS were homeless at the time of their AIDS diagnosis. So we did some aggressive chart lookups to make sure we knew where their housing status was. And there were about 700 people who, at the time of their AIDS diagnosis, were homeless. All right? And that blue line represents the natural occurrence of what happened to their mortality over a 5-year period. And what you see is that only 25% of them were alive after 5 years. And this is during a period of no financial impediments, at least, to antiretroviral treatment. And similar to what Elisa's data shows, if only 18% of the folks who could take their medications are, it's not surprising that the mortality basically reflects exactly what it was like in an era prior to availability of medications. The red line, however, represents the 71 people who were homeless at the time of their AIDS diagnosis, who got into one of those buildings I showed off a second ago called direct access to housing. Among those people, only 2 died over that same 5-year period. There is nothing I have in my black bag that will improve survival among people with homelessness and AIDS, like housing. And there's nothing that Genentech has, or Johnson & Johnson, or anyone else who's producing pharmaceuticals that can improve the mortality of a fragile group of people who are at high risk for death, as this slide shows, can improve the mortality with the intervention of housing. Nothing. Moving ahead to more modern, more contemporary data, now we're looking at the universe of people in San Francisco who have newly diagnosed HIV between the years of 2002 and 2006. The blue line represents the people who are housed, and the red line represents the people who are homeless at the time of their HIV seroprevalence, first blood test positive. And you see that being on that red line is not good. You have a higher likelihood of dying. Over that period of time, we started investing heavily in permanent supportive housing. And we basically inoculated the population of people with HIV and homelessness in San Francisco. And if you were HIV positive after 2006, you see that these 2 lines now are overlapped. We talk a lot about disparities in health. Here is an example of how we eliminated the mortality disparity for people with HIV and homelessness in San Francisco by expanding, on a population basis, availability of housing. It's amazing work. And I really look forward to seeing a very similar slide here in Los Angeles in 5 years hence. Now, not all housing is the same. And one thing that we have as a great advantage in San Francisco is the 43 buildings. We can now look across the buildings and what works and what doesn't. So we can now start to understand how do you do supportive housing for people with HIV and homelessness. And if I go to many of the buildings at least once a month and have clinical rounds where they present hard cases to me and we try to solve these problems. And you know, when I do that, I see that some of these buildings have different qualities, and you can really sort of rank them and even score them on 5 domains. So we have these 43 buildings, and you can rank them by things that will affect health. And the things that affect health, remarkably, architecture, quality of the neighborhood, how sick the people are when they come into the building, homogeneity of the population. In that way, believe it or not, people who are in mixed low income and homeless do better than if they're 100% chronically homeless. And then the quality of the on-site services, we put so much emphasis on that last domain. But yet, that's the only thing pretty much we can change once the building opens. So getting it right upon building is very important. And just comparing 2 buildings that we have, this one, Kelly Cullen Community, and then Mission Creek, which I rank them on the score based on these 5 domains. And Mission Creek is a mixed building for seniors, 62 years and older, 11 HOPWA units there for people with HIV over 62, which still gives me chills when I say that, because I didn't think when I started doing this work we were going to have people over 62 who are moving into permanent supportive housing. Anyway, if you rank that building, the neighborhood is very good, the housing quality is excellent, the severity of illness of the people who move in there is high, so they get a low score, because you want to, you know, the more sick people are, the harder it is to do good quality. The quality of on-site services, not so great. They actually have 1 case manager for 50 homeless tenants, and then it's a mixed population, so you maximize the score. I also gave them a bonus because they have a very strong community. So that gets a score of 12 in this little scale that I made up. And that's above a threshold of 9. And I've found, going across all these buildings, that if you don't get above that threshold of 9, the building just doesn't perform. People die when they shouldn't, people move out when they shouldn't, and people use emergency departments and so forth and get inpatient when they shouldn't. So the quality of these 5 domains is really critical to the health outcomes. So housing not just is important, but the quality of the housing is critical. And then this other building, this 172 unit building, it's below the threshold, but yet the support services could be better. And that's where we're really investing our time, is trying to move that up to its maximum score of 4 in that domain. And once it gets there, I think it will start to perform. But right now, people are dying when they shouldn't and so on. So it's very interesting. And this is, unfortunately, okay, I had to move ahead there, to this last study, again, about the type of services that are being done. So we want to hypothesize how important nursing services is in permanent supportive housing. No one has ever looked at nursing services across permanent supportive housing. And our hypothesis was that if the people who are in the building really are in great medical need, then there'll be a greater impact of having nurses on site on the health of the tenants who live there. So it's just one complicated slide that I'm going to walk you through. Let's see. So look here at these 2 bar graphs. Oops. What we found is that if you look across all of our buildings, and half of the people are in buildings who are, half of the HIV positive people are in buildings with nurses, and half are not. If you look at their emergency department utilization across just looking at the 2 buildings, 2 different types of buildings, you don't see much difference. But then if you stratify within each of the buildings, people who have mental health, substance abuse, and HIV, you see that in those subpopulations, buildings that have no nursing have almost no improvement in emergency department use after they move indoors. That's what that shows. Is the blue, which is before people move indoors, hardly becomes less after they move into permanent supportive housing. However, if you are HIV positive, a substance user, and have chronic mental health problems, and you move into a building with a nurse, your utilization of emergency department dramatically decreases. So what this shows is that if you are stratifying who you put into which buildings, not just by putting people who are sicker into more beautiful buildings, but also putting people who have more complex medical and psychiatric problems into buildings with nurses, you get a lot more bang for the buck. And in fact, we just costed it out. And we found that if you are a triply diagnosed person and you are placed in a permanent supportive housing building in San Francisco, if there are 36 of you or more, the cost savings just in emergency department utilization alone pays for the nurse. So if we can find a way to get all these systems working together so that we understand the cost savings of investing in nursing will be repaid just in emergency department use if we are able to target these things. It's complicated, nuanced stuff, but that's where we are right now in supportive housing. We're at 2.0. It's not just take whoever's on the street and move them indoors. You have to find out who they are, what they need, and match up the services with what they need, with what is available on site. So briefly about cost, we do all these things because it's the right thing to do when we're trying to improve quality. That's why I went to medical school. We're trying to make it so that people have a better quality of life. But remarkably, permanent supportive housing actually reduces public expenditures. Previous HUD Secretary Sean Donovan, when he was on The Daily Show, said this wonderful quote. I love this from The Daily Show. Less expensive to be in housing than on the streets. And then there's this great study, which is out of Canada, so almost none of you guys pay attention to it, but it's such a fantastic study because it gets to this exact issue in such a nuanced and important way. Is they did a randomized trial of 3,000 homeless people in Canada. So 1,500 people got housed and 1,500 didn't. So that's a pretty, for me, unethical study, but it was done. Did it in Canada, so we should take advantage of the data. And it showed that if people were in the top 10% of utilization of healthcare services and they were moved into permanent supportive housing, every dollar spent on housing reduced healthcare costs by 10. And if they're in the next 40% of utilization, it was a 1-to-1, and if they're in the bottom 50%, they spent more money on housing than they recouped in healthcare. This is a blueprint for how you do permanent supportive housing in this country. So I just want to leave with some few conclusions, is treating housing, targeting housing is what it says, in fact, targeting housing towards homeless adults with HIV reduces mortality disparity, right? Old data, positive, powerful, at this point, in my mind, unequivocal. Targeting nursing towards people who have triply diagnosed saves money and recoups the cost of the nurse and improves quality of life. Quality of environment is important. And targeting high users of the healthcare system towards housing reduces overall costs. Trying to put this all together into some simple analogies, I've come up with a couple ideas. Think of homelessness as like a cough, okay? When you're a doctor and someone comes into your office who has a cough, most people are gonna get better because they have a viral illness and you don't need antibiotics, right? So think of most people who are on the streets as being economically homeless, not chronically homeless, and they don't necessarily, at least in softer housing markets, need government-supported permanent supportive housing. However, maybe 10% of the people who come with a cough have a pneumonia. And the only way you're going to find that out is you put a stethoscope on their chest and you get a chest x-ray. For those 10% of the people who have pneumonia, you need to give them an antibiotic, in this case, permanent supportive housing. And then you have someone cough up a big lungy and you send it to the lab and it comes back as growing one bacteria or another. And that helps you figure out which antibiotic you should use. Should you use penicillin or erythromycin, tetracycline, whatever? So you can think about that in the same way that we have to try to attend to housing and homelessness. Most people in soft housing markets don't need permanent supportive housing. But the people who are really sick need it, or they will not get better. And then once you have that population of people who you know need it, you need to assess what's really going on with their lives and attach them to the right type of housing so that they can most effectively benefit from the public investment. And it will reduce cost. So I think that's something I was thinking about in the plane today. I hope it works. Think it makes sense? Maybe? And I'm happy to take some more questions. Now we have, I think, some more opportunity for conversation. So thank you very much for your attention.